thought of that, will the pioglitazone is equally bad or good? We know the data of pioglitazone, but how long we should continue the pioglitazone? So is it any way by which we can do, or HOMA-IR, if you have significant decrease, can you change? After BCA, if you find the visceral fat improves, visceral fat decreases, can you stop your pioglitazone? There is no data such, and if you find that if it is possible, you can publish that data also. So glitazone. Similarly, now GLP-1 is a very hot topic. They have already published that with 5 kg, 1 kg weight loss. So whether in India, do we have similar type of data? Do we lose more protein? Do we lose more fat? We don't know. DEXA is not commonly done, but BC had become very common and popular, so we can use that BC also. Uses of CGM, again I tell we, doctors are poor, our patients are not poor. So this is what we don't explain our patient. Don't feel, that suppose someone is a primary care physician and after 2 years, constantly telling their each and every patient for continuous glucose monitoring wherever it is required or needed as per the guideline. And after 2 years of your continuously telling the patients for CGM, suppose you could not convince a single patient. Don't feel bad. Even you are doing good thing for the patient, because whatever science is telling, you are telling your patients. Now, suppose patient tomorrow goes to some tertiary care place or some other diabetologist or a senior endocrinologist, and that doctor also tells, no, you have to use the continuous glucose monitoring. You inform the patient first time, the patient will take that. So like this is happening when insulin pump I am using. If one of the primary care physician anywhere in Gujarat, if they inform the patient about the insulin pump, suppose patient had come to me, now he knows about that there is something called insulin pump. Some doctor in Rajkot, Jamnagar, Junagadh, Bhavnagar, Mehsana, some place, some taluka, they inform the patient there is something called insulin pump or AID. That patient get convinced immediately. If I am the first one to tell the patient, probably he may not get convinced, but I am sure he may go back to you, any of you, and then he will be confirmed and he may be convinced by you. So, what I will say that the patient doctor who had invested time in that particular patient, for whatever reason, he explained the patient and invested the time, it will not get best. Somewhere, patient will be. Like the same thing is happening in cardiology. They were explaining each and every primary care physician. If you find coronary artery disease, if you see changes, if you get CPK-MB high, the TROPA is high, get admitted, ask this is the standard of care. Get your angio, get revascularization. This is what to be done. You are not the one who is doing it. We are not the one who is doing it. We just ask the patient to either admit it or we treat the patient. But now we don't use we used to give them all therapy before 20-25 years and getting admitted and giving them everything. But now today we are not giving. We physician left out and we told no, go back to either go to cardiologist. And now the government of India started giving 5 lakhs rupees for getting angiography, plasty, revascularization, everything is free. So this is something 25 years down the line. If we want to see India in 2047, 100 years of independence as a developed country, which is already one of the largest economy in the world. We are the 4th largest economy and fastest growing economy in the world. So I think this is the time we have to start taking care of all our diabetic patients, giving them best technology, at least asking them, give them an offer them, maybe in down the line 5 years, 10 years, 20 years, they all will be on the best of the best therapy. It's not the cost, it is, I think, we can't convince our patients, and sometimes we feel that it's unnecessarily we are wasting the time, it is of no use for our patient to do. Same thing is happening for GLP. You tell for the GLP-1, I am sure patient may not take at your clinic, maybe in the next clinic he will take the GLP-1. So give the best therapy for the patient. Use the best technology which is available for our patients, use it, and at least do electronic medical record system. That is one thing which we can do all without increasing any cost to our patient, but it will help humankind, it will help diabetes care, it will help medicine, healthcare, and someone probably like 1 million or those patients' data were there in HealthPlix. So I could assess them, I could see them, and I could publish one paper. So if someone have not written that paper, I would not have done that paper also. So, this is what we can do. Once again, thank you, Durvi. I don't know anything about the healthcare because healthcare is a very big, I think, something technology in diabetes. 4 things which I know. One is electronic medical records, definitely CGM and pump therapy and AI. Yesterday there was a debate. There is a artificial intelligence CGM, which is predictive CGM, which will be there. Within few months, Roche is introducing a continuous glucose monitoring, which will predict your sugar, that what will happen after 2 hours. So if you are using it continuously, the sensor will understand also your lifestyle. He will able to know that you are eating every day 2 o'clock. What will be your sugar maybe at 1:30? What will happen to your sugar pre-lunch? How much amount of food which you normally take and normally how much sugar increases. So you will also able to predict that today you have taken this much insulin or you are going to take, probably your post-lunch will be like this. So a patient can understand, a doctor will able to understand also, and he may increase or decrease the dose as per the predictive glucose value. At present what we are doing is with a real-time value we try to treat it. But with predictive glucose monitoring, it will help your patient. So that is going to be there in month of maybe March. So Fab we will be introducing, if it will come in March, in Diabetes India we will be introducing this product. But there are many more glucose monitor, continuous glucose monitor which started coming in India. More than 5 companies are already there. So, and a lot of technology in diabetic foot care. I heard that your talk and your workshop was fantastic. Everybody enjoyed. So a lot of technology had come in diabetic foot care also. Most of the surgeon, they need to know more, and the physician need to know how to prevent it. I mean, any amputation anywhere in the world, who is responsible? It is the physician who is responsible. We have not seen that patient with the callosity, we have not seen the patient with the pressure, we could not offload, we could not teach. So actually amputation, who is getting, actually we are at fault. We have not explained the patient. Similarly, I tell that all type 1 who are dying since last so many years, in spite of physicians, we are responsible for them because we could not teach them, and they all are dying in their 30s and 40s. We just feel that, oh, sorry, someone is type 1, we can't do anything, we are just giving insulin. But this is, so these 3-4 things which are there, technology in diabetes, but in technology in healthcare, in eye, in foot, in heart, in everywhere, technology usage is very, very high. And we Indians accept technology very, very fast, highest user of smartphone in the world. So I am sure this technology, if we start talking to our patient, most of our patient will start accepting it in more and more. RSSDI have one project, which is with Kyoto Technology. There is a one company, and in IIT Mumbai, if you have any project which is related to technology, it may be new, then they offer 50 lakhs rupees for a project. That's for 2 years. ETTD Asia, which is a technology association of diabetes, they do one major meeting in Barcelona and Asian also. So they have $10,000 a grant, which is for any technology, which is maybe just a project, which will help for diabetes or improve diabetes care. They are offering that $10,000, and the same $10,000 for Barcelona, which is in March. So they have 2 projects you can write. For developing countries, they will be very helpful. I am part of their ATTD as a in committee, so we'll be very happy if you want to forward that project. Thank you very much once again. Thank you.
No. Your panel questions back.
Thank you, sir. It was very informative and always pleasure to listen to you.
Banshi sir.